Hello, everyone. It is 1 o'clock. Thank you so much for continuing to stay with us and be logged on for the first day of our conference. This is our big feature keynote of the day, Dr. Sonu. I'm going to hand it over to Angie Boy from CHOA to introduce our keynote.
Great. Thank you so much for joining us. Thank you, Jill. I have the pleasure of introducing Dr. Sonu. He is an assistant professor of internal medicine and pediatrics at Emory University School of Medicine and the associate program director for the Emory J. Willis Hurst Internal Medicine Residency Program at Grady Health System. His research interests include adverse childhood experiences, trauma-informed care, advancing health equity, and addressing social determinants of health in clinical care settings. He is a passionate ACEs educator and is engaged in efforts to build community consensus around responding to and preventing ACEs through cross-sector approaches. I'm so excited that he is here to speak with us today, and I think we all stand to learn something from him. So with that, I will turn it over to you.
Thank you so much, Angie. And let me share my slides here. Let me know if that's coming out funny or if you can't see it, but I'm going to assume it's working. So good afternoon, everybody. I've heard some great feedback about this morning's events and workshops, and so I'm so thrilled to hear that it's been fruitful and productive. I am just honored to be here right now to be able to share with you some of my thoughts on how we can move the needle on preventing child abuse and maltreatment. And I've titled the presentation I'm going to give as Being the Village. Let me try to move this out of the way. There we go. Being the Village and Breaking Cycles of Trauma, the case for supporting caregivers in a two-generation approach. And what I've really done with this talk is I've tried to convey my perspective as a primary care physician first, but also someone who likes to consider myself a public health clinician. And with both of those hats on, that's how I'd like to sort of introduce this topic and move forward. So what we're going to be talking about today is a lot, and hopefully I can get through it all, but hang with me and we'll get there. Before I move on, I do want to just caveat that some of what we're going to be talking about today is personal and it's real life. And some of it might strike a nerve and it may hit close to home. And obviously, that's not intended to elicit any reactions like that. But if it happens, please feel free to just step away and take a break. You do not need to stay glued to the screen here. But I understand that, we're all living our lives right now. We all have had experiences growing up. Some good, some not so good, and some of that might come up as we continue on in this presentation. So when Angie first asked me to give this talk for this conference, she gave me the prompt, how can we prevent ACEs? And so this is our starting premise, right? We start with a question: how can we prevent ACEs? How can we think about going upstream? What should our priorities be if we aspire to prevent child abuse and neglect? And so what I'll say is we have to talk about some tough things, but if you can bear with me, we will reach a point of hopefulness and direction. And I think just looking forward to what Dr. Dana Susskind is going to talk about tomorrow, I think what I'm going to be talking about today actually might set her up very well. For the last 2 weeks, and I'm seeing literally for the last 2 weeks, I was at Grady every day, attending on the medicine wards. And I was witness to the innumerable consequences of childhood trauma and adversity. Let me just give you a sample of some of the patients who I met, again, just in the last 2 weeks. So I met Mr. E. He's a man with HIV, and tragically, he did not believe he had HIV. And as a result, he came to us suffering some very serious complications from his illness. And it turns out, as we got to know him, that in his childhood, he was abandoned by multiple family members and friends. And it really created this inability for him to be able to trust people. And when he had a complication in the hospital, when he was admitted for an HIV-related complication in 2018, just 4 years ago, that's when he stopped believing he had HIV. He has always had mistrust of authority figures, and when he suffered this complication in 2018, he felt betrayed. He effectively felt betrayed by the health system, and ever since, he has been suffering the consequences of that, and he doesn't believe that he has HIV to this day. I met Mrs. M, who had a long history of childhood abuse and maltreatment, especially at the hands of her father. And she came to us with very severe asthma, very, very severe persistent asthma, where she had been intubated multiple times. And what was interesting about her presentation was that even though her asthma was severe, we were able to get it better rather quickly, but she continued to wheeze. And as we got to know her, it came out that currently, in present day, she had been experiencing intimate partner violence by her partner, who in particular was laying his hands on her by choking her. And anytime someone would come in the room, she would immediately tighten up and start wheezing from her neck. And so this was causing all kinds of confusion on the part of the health team, because people were throwing steroids at her, albuterol treatments that were really unnecessary when the problem was up here. And one last example, and I have many more I could choose from, but we met Mr. M, who was a man who came to us for a Tylenol overdose. He tried to commit suicide by overdosing on Tylenol. And he actually came from the federal penitentiary. And he had had a long history of multiple suicide attempts. And when I got to know him, he basically stated he had been alone his entire life, been in and out of juvenile detention centers, jails, and prisons, and was diagnosed with schizophrenia at age 10. So all to say, like, I'm so glad to be here today, and I'm here to say too, like, on the other side of the street, where in the adult world things are bad, y'all. Like we are dealing with some things that it's not even like we're putting out fires. We're encountering conditions and diseases and complications from diseases that we cannot treat. And increasingly, it is concerning that we're not actually addressing the root cause of what is putting people on these trajectories of poor health and morbidity. So, right, all to say, I'm really glad to be here and say too, like, what we see every day at Grady is so often the aftermath of unaddressed and unacknowledged, unbuffered trauma in childhood. Let me give us a quick recap on this relationship between trauma and adversity. I think I'm definitely speaking to the home crowd here, so I won't spend too much time on this, but a lot of what we know about trauma and health is derived from this landmark study called the Adverse Childhood Experiences Study that was published in 1998. Now, this study made a big splash, or it's making a big splash, I guess, in recent years, because in the 90s at least, the predominant narrative about who had trauma was really limited to combat veterans and victims of intimate partner violence or sexual trauma. But what the ACE study did for us was it gave us information about the effects and prevalence of trauma, specifically adverse childhood experiences, in a group, in a large sample that more closely resembled the general public. Again, this was done in the mid-90s in San Diego, California. And so out of over 17,000 adults, what they learned were two really important things. First, the prevalence of trauma was common. Over half of these 17,000 participants had at least one ACE or more. About 1 in 8 had 4 of these events or more. The second thing that's really important to know about the study was that these researchers observed a dose-dependent relationship between the number of these adverse childhood experiences and a wide array of undesired health outcomes. So in broad strokes, what they found was that, again, the more ACEs a person had, the higher risk they would be for things like smoking cigarettes, IV drug use, heavy drinking of alcohol. They'd be at higher risk for mental health problems like depression, anxiety, PTSD, a history of suicidality, and even schizophrenia. And then the thing that got me hooked on this topic was they observed this very robust relationship between ACEs and chronic diseases that show up in middle adulthood. Things like COPD or asthma, ischemic heart disease, diabetes, liver disease, non-skin types of cancer, and especially autoimmune disease and somatic complaints. And then they also found that ACEs don't just affect our health in the traditional sense, but our social well-being as well. And we know that ACEs cause all sorts of disruptions all in the school age years, ranging from academic failure to school delinquency and attrition, as well as unmet social needs. So ACEs are strongly related to financial instability and job unemployment. And so overall, ACEs does not care about how we have arranged our society, how we have sort of divided ourselves into silos. We've got the education system here and the health system there and the justice system here and social services over here. ACEs will cause problems really wherever it can if allowed to. I just wanted to show you an example of the breadth of outcomes related to ACEs and just to signal like this is how important this problem is, because ACEs has a relationship with all of these outcomes listed here, and this has been demonstrated in study after study. Now, when we think about childhood adversity as a whole, we know that ACEs are not just limited to things that occur in the home or things that occur between people. We know that there are other ACEs that operate on a much broader level that are important to our health. And so if the leaves, if we can think about ACEs and the interpersonal ACEs that occur inside the home as represented by the leaves and the branches here, the roots of the tree are what we call adverse community environments. And these are things like poverty, violence in the community, joblessness or economic disadvantage, unstable housing, and especially racism and discrimination. And then beyond this is the soil that can influence and inform this tree's future health trajectory. And the soil around the tree, we refer to these as adverse collective historical events, and there's a lot of data, a lot of really compelling studies from the field of epigenetics to support this phenomenon, and I'll talk a little bit about that in a second. But when you think about this tree, buried within each level of this illustration is another aspect of trauma that is a little hard to see at first. But this aspect of trauma actually threads all throughout all of these levels. And what I'm talking about specifically is intergenerational trauma. As a primary care doctor, I think it's absolutely essential to have an understanding of intergenerational trauma, specifically in the care of children. What is intergenerational trauma? Well, there's many definitions out there, but one concise one that I like is it's the cumulative emotional and psychological wounding that's transmitted from one generation to the next in the absence of direct exposure. It's when trauma experienced by one generation affects the health and well-being of subsequent generations. And sometimes this does mean that certain types of trauma are cyclical and are passed on. So for example, physical abuse. But more often, what's actually passed on are not the actual traumas themselves, but the effects of those trauma that affected the parent when they were a child. And because this is largely still, I don't know if it's unknown, but it's certainly unacknowledged and unaddressed, and sometimes even actively suppressed within families, the cycle it just really continues on and on. Now, a couple caveats that I want to share about intergenerational trauma before I go on is that one, it's not an intentional act. Just because a child might be affected by intergenerational trauma in the family does not mean that the parents hate that child or they want to do ill to that child. Actually, most of the time, the effects of intergenerational trauma are really more accurately described as collateral damage, collateral consequences. Another thing about intergenerational trauma is that it doesn't happen all the time. Also, it's not always problematic. So even though there might be some behaviors that are not the most ideal in a family, it doesn't mean that those behaviors are going to cause pathology in the child, but really might just be a flavor of the family. And then the last thing is, and this is, I'm going to say this over and over again in this talk, is intergenerational trauma is only part of the story. It's only one aspect of a family's legacy, and it's not the only thing that we should be focusing on. In fact, the story of human history, especially within families, is really one of perseverance and rising above and overcoming. And I don't want that to be missed or fall through as we talk about this. All that being said, it is still important to acknowledge the impact of intergenerational trauma if we want to, again, consider that question, how do we prevent child abuse and maltreatment? I want to show you some studies that highlight the effect of intergenerational trauma on some hard outcomes. So this was a study that included over 2,500 children. And what they did was they assessed parental ACEs, and then they also assessed how this affected child's behavior. And all these children were of school age. And what they found was that children of parents who had 4 ACEs or more, they were 2 times greater. They were at 2 times greater risk for hyperactivity and more than 4 times greater risk for having some kind of emotional or mental health disturbance. Now, this is rather general, and this is also a cross-sectional study. And there is prospective data, however. So this is one of those examples of a longitudinal study in highlighting the effects of intergenerational trauma. And again, the reason this paper has stuck with me is because through a longitudinal study design, it shows a relationship between maternal stress, specifically intimate partner violence, and child development outcomes. And so what they found with over 10,000 parent-child dyads, about 11,000 parent-child units, was that when they took mothers who had a positive intimate partner violence screen when their child was born, and they compared those mothers against mothers who had a negative IPV screen at the birth of their child, what they found was that 5 years later, prospectively 5 years later, when they assessed the child's functioning in different domains of well-being, they found that those mothers who had a positive IPV screen, their children were at much greater risk for being vulnerable or scored as vulnerable in the domains of communication, emotional regulation, cognitive development, physical health and well-being, and even social competence. So there's something happening between the mother or the parent's stress and the child's readiness to learn and make friends and be healthy at kindergarten. Now, the same study also looked at some different outcomes. And again, those mothers with a positive IPV screen at their child's birth, 5 years later, what we saw was that compared to those mothers who did not have a positive IPV screen at birth, those children were at much greater risk for ADHD, acute illnesses like pneumonia, hospitalization secondary to injury. They were almost 2 times more likely to be hospitalized from injury. And then they also tracked different outcomes related to the mother. So a mother who had a positive IP screen at their child's birth was more than 2 times likely to develop a mood or anxiety disorder, and over 3 times likely to develop a substance use problem. So how is all this happening? I mean, what exactly is trauma, like trauma in the parent? How would it affect the child if, especially maybe the parent doesn't even talk about their trauma or tries their best to sort of keep it under wraps or keep it suppressed in front of their child? Well, there's several different models out there, but one that I thought was that sort of brought all these together, I've shown here. And so here's how it kind of works. First of all, let me caveat this by saying, just because, again, intergenerational trauma is occurring, it does not mean that parents don't love the child. And when I say parents, I'm also referring to any caregiver that is taking a primary role in that child's life. It doesn't have to be a family member. It could be a foster parent, an adoptive parent, a distant relative, or some other adult who's a consistent presence in the child's life. It doesn't mean that just because intergenerational trauma is occurring that the parents don't love the child. They may deeply care for the child. But the bottom line is that sometimes the child's actual experience is quite discordant from the parent's intent. Things like unaddressed parental ACEs, mental health problems, and substance use disorders in parents, they can create this kind of social and relational environment that promotes the following potential risk factors. So the first, epigenetics. Epigenetics is the study of how experiences can influence our biology and gene expression across generations. And there's a growing consensus that that both positive and negative lived experiences can actually be embedded into our epigenome and then affect which genes are transcribed and made into proteins. And the real clinical implications of this, of epigenetics, is that some of the most active parts of the epigenome regulate the expression of genes that either protect us or sensitize us to stress, depression, anxiety, addiction, and so on. The second factor that's important are the attachment patterns in primary relationships. So poor or insecure attachment or disorganized attachment between parent and child, that's a well-known risk factor that's associated with poor sense of self in the child, decreased self-regulation in the child, mental health problems, and overall decreased resilience. Then there's toxic stress, which I talk about a lot. Toxic stress refers to both the neurobiological and neurodevelopmental effects of adversity on our physiology. And toxic stress really implies a hijacking of a good thing gone bad. And the good thing is our stress response system, which was designed to respond to acute stress, but under settings of a chronic adversity, when that stress response can't turn off, when it's constantly being stimulated, constantly being activated, this can really create cascades of chronic inflammation that do not wane. And in the adult world, there is a lot of excitement right now, a lot of research, especially in cardiovascular research, that is centering around inflammation as the key pathophysiologic process, as the key problem. And things like high cholesterol and high blood pressure and a high A1C and diabetes, these are all sort of signals or markers of inflammation. And the fourth thing fourth sort of consequence of intergenerational trauma are what we learn as normal behaviors. Most children normalize the way families cope, and they normalize the way parents cope. And so, for example, if a child saw their mother or father drinking alcohol as a means to deal with stress, not only might there already be some kind of genetic or epigenetic predisposition for addiction, but the behavior of drinking when you feel stressed might feel right because it might feel familiar. But there are also more subtle ways I think the learned behavior piece sort of plays out. So for example, some families, and I think this is actually a lot more common than we realize, but some families might choose to bury pain and hurt when a tragic event happens or when a traumatic event affects the family. Instead of talking about it, which is what the child may be looking for or need, it's buried. And so that also can create this sort of learned or normalized dynamic where when problems occur in the family, we don't really talk about it. We're just left to sort of deal with the emotional distress on our own. So why do we care about this? Well, I mean, I think the reason is obviated, but why specifically about intergenerational trauma? What is it about this topic that relates to preventing childhood maltreatment? Well, first, I think it's a fundamental lens that we have to put on as we help children specifically. And then if we think about how to help prevent childhood trauma, if we understand that so much of it is a dynamic that's passed on from generation to generation, then I think that really begs us and moves us to think about how to change and how we, in terms of how we can support and approach caregivers. When we can appreciate the reality of intergenerational trauma, we can actually start to think about where to focus our efforts. So what I mean by that is if we think about intergenerational trauma as this ongoing chain or cycle of events, I think the place to intervene and break the cycle really is at the level of parents. This is the part of the chain that is most malleable, that has the greatest potential to change, the greatest impact if there is change. And I think on some level, this is obvious, especially for this crowd, but I just have to say it, parents and caregivers are the key to preventing ACEs on an interpersonal level. I need to say it because as a pediatrician, what I'm seeing every week when I'm in clinic are parents who are among the most stressed, yes, yet least supported groups in our society. And if we really want to talk about and think about preventing ACEs, we have to be willing to figure out ways to support parents early on. And I'm going to spend the rest of my time making a case for this and explaining why. So in the middle of this Venn diagram, which is from this paper by Isabel et al., and where they specifically talk about preventing intergenerational trauma transmission, in the middle of this Venn diagram are two things. First, on the left, you see resolving parental trauma. So when we, as an approach, what this means is supporting parents in their own healing and processing of past traumatic or adverse events. And what this can do is help raise awareness in the parents of certain, what kind of behavioral tendencies or reaction patterns are being passed on or normalized. So for example, going back to the drinking to solve problems or deal with stress, I have met more than a few patients at Grady with an alcohol use problem who told me verbatim, I learned how to drink because that's how I saw everybody else around me dealing with their problems. And so when we can help people draw that connection, wait, actually the drinking is a coping mechanism that you're trying to self-medicate with, then it helps people sort of understand, wait a minute, this tendency, my proclivity for wanting to drink when I'm stressed is not a irreversible thing. It's not something that I have to do. It's not something that's inevitability. The other piece of breaking this cycle of intergenerational trauma is this idea of supporting parent-infant attachment. And I gotta say, when I first started on this topic, I did not know how important this piece was. But the more I read about this topic, the more I understand about neurobiology, the more I understand child development, and the more I'm seeing sort of this convergence of research from so many fields on how to prevent trauma, it really does come down to the simple recommendation of really supporting that parent-infant attachment. So let me just illustrate how important this is with a few slides. We know that from decades of research, infants are born with over 100 billion neurons. And this represents an incredible, but nonetheless at the same time, rather undifferentiated potential. We've also known for a long time that healthy brain development is fundamentally experience dependent, which means that postnatal experiences, postnatal environments, they build on the existing genetic template that a child is born with, and they help shape the way the brain develops. And then in the first 2 to 3 years of life, there's this dramatic proliferation of the neuronal network within the brain. And in the few years after that, there's this period of pruning. And so there's a saying in neuroscience and neurobiology where neurons that fire together will wire together. And on the flip side, neurons that do not fire together will not wire together as readily. And I think Dr. Susskind is going to talk about this if she talks about the 20 or 30 million word study, which certainly has relevance to brain development in early childhood years. It's estimated that about 90% of a child's brain development occurs before the age of 5. And I put this here because this helps us to understand why the early childhood years are a particularly sensitive and vulnerable period for the effects of trauma or adversity. The earlier that stress or trauma is encountered, if unbuffered, if unmitigated by these healthy relationships, the more cascading and widespread its impact. And we see this in several prospective studies as well as the ACE study. What's also important to understand is that toxic stress negatively affects the development of really important regions of the brain that are important for learning and planning and coping with stress, self-regulating, regulating emotions, learning to differentiate real from perceived threat. And what we learned is that studies among children who have been physically abused, for example, they have found that the normal inhibition that the prefrontal cortex has on the amygdala, the sort of brake effect that our thinking brain has on our survival brain, that is substantially lowered, meaning the pressure on the brake is softer in the setting of abuse. That means that these children have a lower threshold of activation of the amygdala, that fear response center, the smoke alarm of our brains, and thus they are at higher risk of interpreting even benign signals as threats, which means that triggers a hypervigilant response, emotional dysregulation, explosive tempers, or even dissociation. And all of these, of course, are undesired behaviors both in the home and at school. So the main point here that I want to stress is that each of these regions that are on the slide and more are sensitive to the effects of trauma, especially in the absence of healthy caregiver relationships in the developing brain, in the early childhood years. One thing I want to show you that I want to highlight here are some of the behavioral adaptations or behavioral outputs of toxic stress and trauma. And I'm really careful to say it like that. These are not just behaviors that appear de novo, but these are adaptations, actually behavioral responses and adaptations that are downstream from a child, the way a child's adapting to an environment of trauma. The two things, hypervigilance and dissociation, these are really maladaptations to trauma, whereas emotional dysregulation, that's more perhaps a consequence of trauma. And the idea is that when the brain is spending more time in survival mode, when it's spending more and more energy throughout time sort of surveying for threat and living in an unpredictable or chaotic environment, not knowing what to expect, when there's no routine, sort of consistency in the caregiving, and spending less if it's spending more time in survival mode, it's by definition spending less time in learning mode. It's more concerned with dealing with threats than exploring the world and learning. And the last thing I'll say about this slide is, just as children demonstrate these predictable stress responses, parents do as well. But here's the thing. We also know that despite all the evidence on trauma and health, that adversity is not destiny. Far from it. Many of us know this when we take inventory of our personal lives, when we look at the lives of our loved ones, our families. We can see internally how much we've really overcome to get to where we are today. So what are the factors that influence whether a person develops symptoms from trauma or not? Well, there are many, but I think the four sort of top ones that come to my mind are, first, the nature of the trauma, the severity, number of traumatic events, the cumulative burden, and the duration. Now, this doesn't mean that just because two people experience the same event, they're going to have the same outcome. There are individual factors that matter as well, such as what a child is born with in terms of genes and their epigenome. The developmental stage at which the trauma occurs is also an important factor in terms of whether a person develops symptoms or not. But the most important one that really that is the most malleable, I would argue, is the availability of buffering relationships. And this is really a consensus of many decades of research from many different disciplines. It's to me, it's just fascinating how so many different fields are converging on the same notion of the early attachment relationships as being so fundamental to preventing the long-term consequences of trauma. But it's true. Decades and decades of research have found that safe and stable, nurturing, and attuned relationships are powerful drivers of healthy brain development and resilience. Whereas adversity makes us vulnerable, healthy relationships protect us. And how? Why? Well, when a child can grow up in the setting of safety, stability, they are understood, they're in a nurturing context, that actually leads to some powerful indicators of resilience, which I've shown here. Things like mastering developmental skills, having good emotional self-regulation, and that's a really big one. The ability for children to stay with a task, persevere, be able to be flexible, deal with change. And these are things that really depend on the template provided by the caregiver to model from. And the third one is self-advocacy, a belief in oneself. I want to show you a study that really highlights the power of these of strong primary relationships in early childhood. So this was a study that was published recently and led by two of the most active thought leaders in resilience research in pediatrics, Dr. Bethel and Garner at the AEP. And what they did in this study was they used population level data to look at this relationship between social health risks like food insecurity, economic disadvantage, and relational health risks like ACEs against child mental and emotional well-being. I think this study is going to be a landmark study because there's just so much data and so many findings so many lessons from this study that we can draw from. But it really does shed light on this interplay between social risk factors, relational risk factors, and child emotional mental health. So for the sake of time, I'm just going to show you one slide. This is one that really gives me a lot of hope. On the y-axis, we're looking at self-regulation. So what % of children have good self-regulation? We know this has important implications for future success and resilience. On the y-axis, we are looking at 3 different categories of parent-child connection, ranging from very well on the left to not very well on the right. And so for children who have neither social health risks or relational health risks, which you can see on the right there, we see this expected trend. Children whose parents rate their connection as very well on the far left here have the highest prevalence of good self-regulation at about 55%, whereas children with poor parent connection are less than half as likely to have good self-regulation. So already right there, we see this connection between strong parent-child connection and self-regulation. Next, let's look only at the purple line, which represents children with only relational health risk factors and not social health risk factors. So these are children who might have ACEs, and their parents describe themselves as having frequent aggravation with the child. There might be also parental mental health problems. And so here we can also still appreciate this similar downward slope, although there's a lower prevalence of good self-regulation overall. But what this tells us is that even in children who have a relational health risk factor, if parents are able to repair the relationship in favor of a strong parent-child connection, self-regulation in the child goes up. And then lastly, let's look at the blue line. This represents those children with both relational and social health risk factors. Again, we see the same downward slope. We see a lower prevalence of good self-regulation overall. But here's something that we should take note of. On the blue line, 35% of children who were classified as having a strong connection with their parent were observed to have good self-regulation. And so this could be the child whose caregiver is able to receive mental health support or support for a substance use problem. This could be the child of a parent who receives emotional support or parenting support to strengthen their connection with the child. Now, compare that 35% to the 25% prevalence of good self-regulation in those children with neither social or relational health risks. So what's the main point here? First, even among children who have multiple social and relational health risks, if the parent or another consistent adult caregiver is able to have a strong connection with the child, that child can arguably do better than the child who is living in an environment with neither set of risk factors but has a poor connection with the parent. Secondly, if we can move a child with any arrangement of social or relational health risk factors from the right to the far left, we can increase the chances of better self-regulation, which has tremendous life course implications. I want to highlight another study that shows us the power of a healthy relational ecology. So not just the parent within the home, but multiple adult caregivers who are positive influences in a child's life and the community at large. And so this is a large study from a set of Wisconsin adults and found that those who had more positive childhood experiences, or PCEs, they were much less likely to report depression or poor mental health. Now, what are these PCEs? Before we stare too hard, these were defined as a child, you felt able to talk about feelings with your family. You felt your family stood by you during difficult times. You enjoyed participating in community traditions. You felt a sense of belonging in high school and supported by friends. You had 2 or more non-caregiving adults who took a genuine interest, and you felt safe and protected by at least one adult in the home. And so what they found from these positive childhood experiences was that almost half of the adults who only had 0 to 2 of these had depression or poor mental health. And this was compared to just 13% in those adults who had 6 or 7 PCEs. And in their logistic regression model, after they adjusted for common demographics, they found that adults with 6 or 7 PCEs were 70% less likely to report poor mental health, or a history of depression. So all this to say, again, as people who work with children and people who are invested in the health of children, it is so important to zoom out and recognize how important the role of the parent is in the health and well-being of the child. It is so important to support those relationships that parents have with their children, especially in early childhood, because again, the effects of the environment can be cascading across the life course. Going back to this slide, the issue that I want to stress is it's not about love. It's not about whether a parent loves their child, and most do. The far majority do. I really believe that. The challenge is that the intention of love or the signal of love can be distorted, sometimes unrecognizably so, because there's a competing signal coming from the fallout of parental ACEs or unaddressed mental health problems or ongoing substance use issues that can create a context of chronic parental absence, emotional neglect, or even silence around the issue. Or there can be these sort of embedded but problematic behavioral patterns that occur unknowingly because they just feel normal. So I guess what I'm trying to say here is that sometimes the love that's intended is not love that is received. That doesn't mean that the love from the parent is invalidated, but at the same time, it is not the child's job, nor is it within their capacity to be the translator of that corrupted signal. And so this means that we have to do a lot more supporting of parents, because I would say that the far majority would want the effort of their love and their affection to be a clear signal that their child hears and receives. So what can we do to support parents? And again, my caveat is I keep saying parents, but I am also including caregivers and non-biological adults that play a primary role in a child's life. The first thing we can do is reframe how we view caregivers. Instead of expecting that caregivers automatically should know what to do, automatically be ultimately present with their child and on top of every issue that their child is experiencing, what can really help us sort of adopt a more empathetic approach is to have a trauma-informed perspective, and also treat the relationship that the child has with their parent as a target of our interventions as well as the patient. So when we're meeting with that caregiver who is chronically late or challenging or anxious, exhibits some kind of behavior that's counterproductive, what having a trauma-informed approach means is holding in mind that link between trauma and health, trauma and behavior. And what it means is that instead of asking what's wrong with you, we think instead what's happened. Because if trauma is associated with all of these physical and behavioral problems, if it's not something that anybody ever asks for as a child, then saying what's wrong with you is really missing the truth of the matter. And asking what's happened opens us up to understanding what the parent's perspective and their point of view, and it also helps us to appreciate and remember that most parents are doing the best they can with what they've got. The far majority, again, they love their children. At the same time, being trauma-informed doesn't mean we excuse behavior. That behavior doesn't have consequences, but we hold that tension of also acknowledging and remembering that the root cause of a lot of dysfunctional behavior is an experience of trauma or chronic adversity. And the one example I'll share is that I had a mother in clinic who I referred for neurodevelopmental testing. And when she arrived at the specialist's office, she was asked to fill out a range of psychobehavioral assessments for her child who was having some behavioral concerns. And the mother got really frustrated and refused to fill out the questionnaires. And I got a message from the specialist saying, you might need to talk to the mom because it doesn't seem like she's really invested in her care, in the care of her child. Please have her come back when she's ready. And when I looked through the chart and then I asked mom what happened, what she told me was she couldn't read. She didn't know how to read, but she felt embarrassed to disclose that when she was asked to fill out these forms. And so it wasn't because she didn't care about her child. It wasn't because she was spinning her wheels in dysfunction, but she couldn't read, and we didn't acknowledge that on our side. Bruce Perry is shown here, and he's a child psychiatrist who is a leading trauma therapist, and he has this quote which I come back to from time to time. He says that we are born primed for relationships, that our human brains are ready for, we are designed for relationships from birth. But increasingly, we are creating environments and contexts that are relationally impoverished. And so we, in a sense, are kind of swimming upstream by promoting relationships and really trying to highlight the centrality of those primary relationships. Leaving children in front of screens, or letting children sort of be to themselves with smartphones and video games for hours and hours, really undercuts dialogue between parents and children and amongst the family members in general. And this is what he means by relational poverty, this sort of absence of relational, the richness of family and family interactions that historically was more prevalent than it is today. So at Hugh Spalding, we tried to tackle this problem, and we wanted to develop a way for parents to talk about relational health in an efficient manner. For the sake of time, I won't go through this entire analogy, but I might come back to it at the end. Basically, and I'm happy to share this poster as well. We're in the midst of evaluating it, but I'm ready to just get it out there. So if you're interested, please let me know. But we have this balloon analogy, or this basket analogy, where the balloons represent positive childhood experiences, and the rocks that can hang on the basket represent ACEs. And the goal is to get the basket to fly in the air. And the way you can do that is you can either cut off rocks, which implies getting some support for some chronic issues, or you can add more balloons. But the general idea is, listen, some rocks are just never going to be able to be moved from that basket. But as long as we can add more balloons, and we're sort of focused on that, and the way you add balloons is really optimizing that child's relational and social ecology, that child will learn how to be resilient and succeed and flourish. The second thing we can do is support and refer parents who have mental health problems and substance use disorders to get treatment. This, to me, as a med-peds doc, is the elephant in the room. Anytime that I feel like I'm sort of hitting a wall with a mom or a dad, and our concern about the child is sort of mismatched or discordant, at times I found that actually the mother or father was dealing with anxiety, or they were dealing with depression, that sort of made it very difficult for them to see their child for who they were and what was actually going on. Even if we can't do anything about it, even if we're not the therapist or an adult practitioner, listening is therapeutic. It is a trauma-informed practice. Because what this does is, so when a parent shares a part of their story that feels personal or they feel some type of shame about, and when we can stay there and not run out of the room, but we can stay there as a supportive presence and say, this happened and I still like you. I still think the world of you. What that does is build relational capital, and it really helps to sort of dismantle the feeling of shame and build trust. The trauma-informed way to understand addiction is really illustrated by this quote by Dr. Mate. The question is not, when it comes to addiction, the question is not why the addiction, but rather it's why the pain. And it's recognizing that people who have a chronic dependence on a substance or even a behavior are not necessarily loving that substance long-term, but really it's a form of self-medication and coping that has other, of course, collateral consequences. And I just want to show you real quick this Triad of Addiction, which I use to teach the residents sometimes. You have to have three things for addiction. One, a susceptible individual. Usually that means a history of trauma or ACEs. And I love this quote, another quote from Dr. Mate. He says, early emotional loss is a template for all addictions. The second thing that has to be is an addictive substance or behavior. Really anything that predictably increases or stimulates the release of endogenous dopamine and opioids. And then there has to be a current stressor, which in modern day, there are plenty of things that are causing stress to parents. All right, for the sake of time, I'm going to move on. I'll just show real quick. This is a Georgia Quit hotline. So if you want, take a quick screenshot of this. This is a free resource for anybody who calls the hotline. They can get some counseling and a month supply of some nicotine replacement therapy. The third thing we can do is really strive to promote positive parenting strategies and parental well-being. And I wish I could spend an entire 3 hours talking about this, because there is so much good information out there that we just have to be willing to sit, read, and digest it. But what it comes down to is consistency, stability, safety, and nurturing. And this is what Ann Maston, one of the pioneer resilience researchers, quoted as everyday magic. Resilience is not some extraordinary quality, some exceptional gift that is bestowed upon a child, but the way resilience develops is the grind, the long-term grind of a loving and committed adult caregiver in a child's life. It is the least sexy thing. It is the least flashy thing for a child, but it is the exact thing that can really help change a child's trajectory and life course to a more healthy direction. I'm going to quickly go through some general tips that I like to talk about in clinic with respect to positive parenting. And the reason I like these tips is because they are cross-cultural. They're really derived from what we've learned from evolutionary biology and interpersonal neurobiology. And it starts from day one at birth, where we highlight the importance of touch, affection, talking to the baby, using parentese where we vary our voice up and down so the baby's eyes are drawn to our face. And what's interesting about touch is that when the fetus is very young, our skin cells are actually, the origin of our skin cells actually comes from the same sort of undifferentiated cells as our central nervous system and spinal cord. And so I thought that, it's fascinating that our skin cells and our nervous system have a same root origin in terms of cell lines. And I think that just highlights the importance, again, of touch and affection. The importance of play and meaningful play, especially this kind of serve and return, this give and take, can do wonders to building confidence and regulation skills in a child. This is a huge one. So teaching parents to understand, what does it look like when my child is stressed? And how do I sort of understand that behavior? And then how can I sort of expand my emotional container where I don't react to their stress reaction and create more problems, but where I can actually expand my capacity, expand my regulation, and understand what's happening with the child. And I have an example of this in a second. Routines. Routines are really underrated. And I think, for those who have implemented routines in their child's life, you can see the real advantage of how much just having some consistency in the schedule can mitigate undesired behavior. And this last thing is something I'm really keen on emphasizing to all parents. And that's just saying, look, we're not perfect. And this is not about perfection. We will blow up sometimes. We will lose it on our children. We will explode on them, and that happens. It's okay. Be kind to yourself and acknowledge that some of that actually might come from the baggage that was put on us when we were children. But the key is, if we do react in a way that we later regret, the key is to reconcile with the child, mend the relationship, reconcile if you can. Because if you leave that child hanging, what they start to learn and tell themselves is, I am bad. I am the bad kid my mom or dad thinks I am, and I deserve to be punished. And I don't think most parents would want their kids left feeling like that if they lost their temper. Okay, one analogy that I want to highlight very quickly is the Hulk. And I think this is a great way to describe to parents who have children who are school-aged what a stress reaction looks like. And so basically the idea is, this comes from the comic book, the Marvel, Avengers, the Hulk. The idea is that when children are regulated and calm, they are Bruce Banner, the human being, the scientist, the one who is calm, regulated, kind to people, compassionate. But when something is activating or something sets them off, something is triggering, like a bad look from another student, or being told all of a sudden that they have to turn off the video game, brush their teeth, and go to bed, they become the Hulk. Now the Hulk is not aware of who he's hurting, or he's not aware of what he's destroying. All he sees is the color red, and everything is a threat. You cannot reason or rationalize the Hulk to become Bruce Banner. You cannot talk him down to becoming Bruce Banner. The Hulk needs time and space, and especially safety to deactivate. So the next time the Hulk shows up and you don't recognize your child, remember what he needs and what doesn't work. Talking doesn't work. Talking, like saying calm down, you have no reason to be this upset, that usually doesn't work. But sort of creating space, safety, and understanding can help calm down that response in a more effective way. The last thing that I want to highlight very quickly is the big picture. Obviously, everything that we've been talking about with respect to supporting parents is on an interpersonal level, but there are many policies that support parents and parenting that are out there. And this is really where we can start to move the needle on a population level. And I will say that there are already great policies that support families that just need some more support. And these are already applied in other states. But I just want to highlight the importance of expanded paid leave. I think it's so important for parents to have the opportunity, but both mother and father, to have the opportunity to be at home and really invest in that primary relationship with their young infant, again, in that first year of life. The promise of preventing ACEs is that we can reduce things like depression by almost 50%. We can reduce the percentage of people who smoke and use substances by a third, which will have downstream implications on the kinds of chronic diseases that we see in middle adulthood. Okay, so as I summarize, we talked about in the beginning that intergenerational trauma and how the effects of both interpersonal ACEs, community level ACEs, historical ACEs can be transmitted across generations, and how these effects can be imprinted in our biology as well as on our behaviors and norms. But remember, intergenerational trauma is only one part of the story. And that's why, to me, that sort of pushes me to, and it reminds me that we can't allow ourselves to feel defeated or hopeless about helping parents change those trajectories. And bottom line, I think what all this sort of comes down to is what this means for us is that our starting point or frame as we desire to help children is to approach the health of the whole family, and understanding that the health and well-being of parents will directly affect the health and well-being of the child. And what's interesting is that pediatric providers, so nurses and docs and case managers and social workers and those who work with children, the justice system and child welfare, those are the main touch point, not only for children, but also for parents. There is no other entity in the landscape of medicine who is better supported or better suited to support parents than we are. I'll close with this quote. In order to develop normally, a child requires progressively more complex joint activity with one or more adults who have an irrational emotional relationship with the child. Somebody's got to be crazy about that kid. That's number one, first, last, and always. And with that, thank you for your time and attention. I'm happy to take some questions.
Thank you. I'm going to do just one question since we are almost out of time. And this is because I saw a lot in the chat box as well. And we had a question on how do you feel about an organization using the original ACEs questionnaire to get an ACE score on their clients or people that they serve?
Yeah, that's a good question and a controversial topic. One that I have thought quite a bit about. And I will say right now, the ACE questionnaire is really just that. It's a questionnaire. It's not intended to be a screen. A screen in a technical sense is supposed to give you a diagnosis if it exceeds some kind of threshold. And when a person has 2 ACEs or 4 ACEs or 6 ACEs, there is no diagnosis that becomes positive. It really sort of helps us to understand the factors that might be influencing that person's health and well-being. So do I think it's important to know about trauma? Yes, but only in the setting of a trusted, committed partnership and relationship. I will actually ask adults, how is it growing up? And that's my ACE screen, if any, or ACE questionnaire. Because if I ask how was growing up and they say it was terrible, then I'll say, can you tell me more about that? And I just kind of let them lead. But the other reason I really try not to ask about ACEs is because it's not so much the event itself that matters, but how that individual has processed and moved on or not from those events. So it's really the individual factors that determine how a person responds to trauma, not necessarily just the trauma itself. Those 4 factors that I showed before.
Yeah, the perspectives and also those positive experiences that they might have had to mitigate
That's
that
right.
as well. Thank you
That's
so
right.
much, Dr. Sonu. I can only tell you in the chat box that we're seeing people are asking for an encore, a part 2, for it to go longer. They're asking for, did someone get a screenshot of that? Can I have this? So if you don't mind sending the poster over to either Angie, I, or one of my team members, we're going to put that on the conference website, and this recording will be posted for you guys to share and share widely. Dr. Sonu calls himself an ACE educator, and we hope that after today, you guys will go out and do the same, and also to be the positive experience educator